Hello and welcome to the Check Rare podcast. My name is Peter Suzuki, and the topic of today's discussion is a rare inherited lysosomal storage disorder. This podcast is the first of a four-part series in which we will be focusing on alpha-Mannosidosis, a genetic disorder characterized by immune deficiency, facial and skeletal abnormalities, hearing impairment, and intellectual deficit. The effects of this rare disease can vary significantly. In this first part of our four-part series, we will be talking to Laura Buch, a physician assistant who practices medical genetics at the Greenwood Genetic Center in South Carolina. Laura's work is focused around the diagnosis and treatment of patients with abnormal newborn screens, inborn errors of metabolism, and lysosomal storage disorders. She also cares for alpha-Mannosidosis patients. Hello, Laura. Thank you for your time today. Can you introduce yourself and tell us about your work?
Yeah, no, I'm super excited to be here today, Peter. Thanks for having me. Looking forward to kind of sharing some of our experiences here at the Greenwood Genetic Center. But my name's Laura Buch. I'm a PA here at the Greenwood Genetic Center in Greenville, South Carolina. And I've been working here for almost 5 years, primarily working with lysosomal storage disorders, metabolic genetic disorders, and also some general genetics. My work with alpha-Mannosidosis actually started fairly recently. Up until a couple years ago, I didn't have any patients on my roster with alpha-Mannosidosis. There have been a couple followed through the Greenwood Genetic Center for several years, but we didn't have a great treatment on board and approved in the United States at that time. A couple of our patients had been lost to follow-up, and once the new approval for Velmanase alpha came out in the United States this year, they kind of got brought back into clinic and with some renewed interest and vigor for treatment and intervention.
Okay, to start off, what is alpha-Mannosidosis?
So alpha-Mannosidosis, for those who aren't familiar with it, as many people aren't, is a lysosomal storage disorder caused by having two pathogenic alterations in the MAN2B1 gene that leads to a deficiency of an enzyme called alpha-Mannosidosis. And that enzyme works within our lysosomes to help degrade products and recycle them in our cells. And when that enzyme isn't working, then we have accumulation of substrate, which can be toxic, of course, to the lysosome, but then also overall to the cell itself. These cells obviously are all over our bodies. So this disorder, like other lysosomal storage disorders, is multisystemic. It affects many different body systems and it can be progressive. This condition as well, alpha-Mannosidosis, has a lot of variability. So there is a spectrum of involvement with alpha-Mannosidosis and the patients affected by this condition. So being aware of some of the more subtle features and some of the more characteristic features can be very important for healthcare providers and families alike.
What are some of the signs and symptoms of alpha-Mannosidosis?
I think one of the main things to consider with alpha-Mannosidosis when you're looking for symptoms or possible presentation is the fact that there is a lot of overlap with other lysosomal storage disorders. So there are characteristic features that kind of clump together a lot of these disorders and diagnoses, and some of those include things like coarse facial features, skeletal abnormalities. For alpha-Mannosidosis particularly, we have concern for early hearing loss that's mixed in nature. So we see both conductive and sensory neural portions of hearing loss for these patients. In addition to, we have frequent infections. So these patients can be sick really frequently, very early on. They can have enlarged livers and spleen or hepatosplenomegaly, in addition to developmental delays, intellectual disability, and also difficulties with movement and walking.
What are some of the challenges of diagnosing this rare disease?
When we have individuals and diagnoses specifically that are on the RUSP, the Recommended Uniform Screening Panel for Newborn Screening, we're able to screen for and hopefully diagnose patients with these rare diseases early on in life, from infancy and birth. And when we have that capability, it gives us a step up in getting early treatment, early access to treatment for these patients. Without that, there are a lot of challenges to diagnosing these individuals. With any rare disease, of course, we have awareness and education that can always be improved upon, especially for healthcare providers, but also for families and individuals who are seeing their newborn and raising their family from day one. So, what we can see as challenging is, of course, some of these findings can be very subtle. Like I said before, there's kind of this spectrum of involvement with alpha-mannosidosis. And that spectrum can be very severe with communicating hydrocephalus early on, really severe neurological impacts from an early age. And it can be much more mild. So, potentially a relatively normally developing kiddo with a lot of ear infections and maybe some gastroenteritis more so frequently. But really, we see a lot more of those patients who are in that moderate end of the spectrum, kind of right there in the middle, getting diagnosed earlier on, I would say. A lot of these patients struggle with misdiagnosis. So I know for one of the patients that we follow, he carried a genetic diagnosis that was inaccurate for almost 20 years. And that, of course, is exciting for families when we find out that the diagnosis that he actually has treatment available, but can be very frustrating and challenging for that family for the many moons that they were under the impression they had a different diagnosis.
Are there any typical signs and symptoms that healthcare providers could look for that would help them diagnose this rare disease?
Some of the struggles I think that kind of come along with diagnosing alpha-mannosidosis is the broad spectrum of involvement. So we can see these kiddos with frequent infections, with some developmental delays. A lot of kids get sick, and a lot of kids have delays that aren't necessarily related to this diagnosis. With alpha-mannosidosis specifically, we also have, I think, maybe some subtle coarse facial features that can be present early on, but those can be like a mild flattening of the face, maybe a depressed nasal bridge, not necessarily something that an untrained eye is going to pick up on right away. These features can become more apparent with age, but some of the skeletal manifestations like dysostosis multiplex and some of the other involvement may become less obvious over age. So there is a wide variety of challenges associated with diagnosing any rare disease, but especially alpha-mannosidosis.
What tests are used to confirm an alpha-mannosidosis diagnosis?
We are really lucky. We live in an age that has a lot of great genetic testing options available to us. And if you are to suspect alpha-mannosidosis in one of your patients, there are a variety of options available to you. So there are things that can include enzymatic testing, so looking for the alpha-mannosidase enzyme level. That level is going to be low upon diagnosis and sometimes even zero. So we can see it being very minimal to undetectable. This alpha-mannosidase enzyme level is either ordered individually or can be ordered as part of a lysosomal enzyme panel. And these exist at multiple different laboratories across the states, across the world. So you can order those if you are suspecting a lysosomal storage disorder and aren't sure which one, and B, if you're suspecting alpha-mannosidosis, you can order that specifically. With enzymatic testing, that's of course a helpful start, but definitive diagnosis is made when we do gene sequencing. And that genetic sequencing is done either on a blood sample, dried blood spot, or like a salival buccal swab sample. We can test those leukocytes in blood, put them under a microscope, look at them up close, and do gene sequencing to look for any spelling changes, missing or extra pieces by copy number variant in the MAN2B1 gene. And that's the MAN 2B1 gene. When we have two pathogenic alterations, pathogenic meaning disease causing or known to be harmful to the function of a gene, that's when we're able to diagnose alpha-mannosidosis. We're also able to utilize a couple of different levels, other things that can raise our suspicion. We can look at urine oligosaccharide levels, see if those are elevated abnormally in a specific pattern associated with alpha-mannosidosis.
What is your conversation like with newly diagnosed families of this rare disease?
Some of them are children, some of them are adults by the time they make their way to genetics. And for my clinic specifically, we had two patients who already had a diagnosis of alpha-man, but there was no treatment available, and we had put them on kind of a longer term follow-up. So to check in, make sure they were following up with their specific providers and receiving the care that they needed that was available to them at that time, mostly symptomatic management and other intervention for therapies. When a patient comes to our clinic, we are really excited, that they've taken the time to come to our center, whether that means they've had to drive 5 minutes down the road or maybe 2 hours away. They've taken the time out of their day to come to us for a conversation, for medical intervention and education. So we're very grateful for them. We also see that these patients are coming to us after possibly seeing many different specialists and going on what we like to call the diagnostic odyssey. In rare disease, we see this time and time again. It takes years to get a diagnosis. You've seen 5, 6, 7 different medical providers before coming to genetics and receiving genetic testing and education. When they come here, we try to give them as much of an opportunity to tell their story as possible. So where have you been? How long has it been since you started having symptoms? What symptoms are you having? Getting a really good history, allowing the family to tell their story, bringing us into their story and into their timeline, I think is just one of the most rewarding parts of what I get to do, learning about where they've come and where we're going to go. With that medical history, we're also going to perform a very thorough physical examination, looking, of course, at a dysmorphology sort of perspective. So looking for distinctive features, anything that could raise a flag for alpha-mannosidosis. Like we talked about before, we look for those coarse facial features. We look for genu valgum. We look for any previous imaging studies, and are there signs and consideration for dysostosis multiplex, for multiple bone involvement. And then after our physical examination, of course, we're going to talk to the family and counsel them on genetic testing. Do we want to start with an enzyme panel? Are we not sure yet that this patient actually has alpha-mannosidosis, or do we already know the diagnosis and we're going to skip right to treatment and monitoring laboratories? What we do first, if we're trying to get a diagnosis for these patients, is we consider potentially like a broad panel. If we're uncertain exactly where this patient falls on the diagnostic spectrum, maybe we are ordering whole exome sequencing, casting a wide net. Potentially, though, I am more suspicious that there is a lysosomal storage disorder, not maybe sure which one. It is difficult to differentiate sometimes between some of the features with alpha-mannosidosis and maybe a patient with mucopolysaccharidosis type 1 or MPF 1. And so we can order a lysosomal enzyme panel. We can get a urine specimen and look for urine oligosaccharides, or if we're considering an MPS disorder, urine GAGs. And then, of course, we always like to get a sample, if we're able to, of DNA. So if we're able to get a blood draw, a buccal swab, a saliva sample, we can always store that. And if the enzymatic or biochemical testing isn't helpful, we can go for diagnostic sequencing, maybe potentially doing targeted gene sequencing, or like I said before, casting that broad net.
How are patients managed? Are there any treatments?
Yeah, that's a really great question. So management is very, very broad. We have a lot of different healthcare providers who are obviously going to be pulled into the management of these patients. We're going to have, of course, audiology, ENT involved. We might be getting individuals plugged in already or who have already seen allergy or immunology to help rule out other immune deficiencies that could be causing their frequent infections. We can also get them plugged in, of course, with orthopedics, physical therapy, occupational therapy, speech therapy, anything that would help address these patients' developmental delays and give them the best shot of developing those skills moving forward. We, of course, are also going to see patients require different medical intervention over time. So, if we have different, osteoporosis or concerns for bone mineral density, then we might be getting them plugged in with an endocrinologist to help get the treatment started for those deficiencies. When we start thinking then about different interventions, historically, we've seen patients go through hematopoietic stem cell transplant or bone marrow transplant for the treatment of alpha-mannosidosis. We also now, of course, have enzyme replacement therapy available in the United States with Velminase alpha. talking through different treatment options, management options. We want to make sure that our patients are well plugged in with all of the appropriate healthcare providers. We also do like to make sure that the family is well supported. You know, do they have access to patient support groups? Do they, or are they able to be plugged in with national organizations, local families even, who might create a better network for those families? This is a lot of support for the healthcare providers in the home, like mom and dad or other family members who have maybe stepped in to help assist in the care of these patients. What we then do is, if we're able to get treatment started, we reach out to, of course, the pharmaceutical company, to insurance, and trying to get the ball rolling for being able to get them on local infusions so that we can get treatment started as soon as possible.
Can you speak to the effectiveness of hematopoietic stem cell transplantation?
There's been a lot of research in the hematopoietic stem cell transplant for alpha-Mannosidosis. The hope is that, of course, with enzyme replacement therapy alone, we're not able to cross the blood-brain barrier. And so what kind of impacts are we able to see on brain structure, brain function, on central nervous system function in these patients? And so with hematopoietic stem cell transplant, we've been able to see some improvement there, crossing over into the central nervous system and also the peripheral nervous system as well. When we have that impact, we're able to see over time, hopefully, greater benefit to those patients. And with that ongoing body of research, we've been able to see patients also live longer and healthier lives with alpha-Mannosidosis.
How do you measure if a patient is improving?
So oftentimes when we start enzyme replacement therapy, really for any lysosomal storage disorder, we do see a period of improvement in a patient. It's kind of what we call like a honeymoon period. And this is typically a result from the clearance of storage from our lysosomes in the cells in our body. And so the patient starts to feel better, maybe has some improved function. What we have seen is that over time, our long-term goals for enzyme replacement therapy is not really halting disease progression. We haven't been able to get to that point yet. But instead of having this kind of severe decline in symptoms and in quality of life, we're hoping to kind of even out that decline over time to be slower and plateau for longer. Not being able to halt the disease progression entirely is very frustrating, of course, to us as medical practitioners who care very deeply for our patients and their quality of life, but also, of course, to family members who have potentially seen a kiddo that has been happy, healthy, able to be out on a bike, riding around the neighborhood, but then over time losing speech, losing motor function, losing ability to be able to do the things that they've known and loved. So when we have that initiation of treatment, I do like to counsel families. We might have this honeymoon period where we're feeling better, doing very well, and we would like to keep that plateau of feeling good and better going for as long as possible. Over time, though, we do see a slow progression and an eventual decline in our function as a patient. Yeah, when we see patients who are starting treatment or about to start treatment, we like to get a baseline of their current disease involvement. So let's say, for instance, a patient has come to us, they already have had gene sequencing, we know they have alpha-Mannosidosis, but maybe they haven't had an enzyme level measured, that sort of thing. We'll go ahead and get those baseline labs so we're able to see what their baseline enzyme level is, what their oligosaccharide burden is, and then we can monitor those moving forward. We don't recheck the enzyme level moving forward. We don't really expect that to change. But the oligosaccharides, we can continually monitor at each consecutive visit to see hopefully that oligosaccharide burden coming down with efficacious treatment. What we also like to monitor is a patient's antibody resistance to a medication. So we like to see them routinely back. Let's say over time, we get them around every 6 to 12 months. And that antibody level tells us if their body's trying to mount a response to or a reaction to the medication, to the enzyme replacement therapy. Oftentimes, of course, we see that these patients are making minimal to no enzyme. And so the likelihood that they develop some antibody resistance to an enzyme replacement therapy, an enzyme their body's never seen before, is likely. We see that happen. It's just a matter of making sure it doesn't continue trending drastically up and staying elevated for a long period of time. We will also routinely check things like 6-minute walk tests through outside providers who help us perform those, maybe like a 3-minute stair climb test if that's more accessible to a patient or more easily attainable at an outside facility. And we also, of course, like to continue to monitor their home life. Do they feel better? Do the parents feel like, or their caregivers feel like they're interacting better, doing better? We also then may do routine imaging over time as well, looking at things like MRIs, looking at liver and spleen burden, how large their organs are, and then also making sure that they are maintaining their checkup with other healthcare providers. So annual or yearly hearing exams through an audiologist, maybe an ophthalmologist, or eye exams so we can make sure that their vision is still good. And then also a neurologist is usually on board to help determine any progression of their disorder. We also like to see over time, knowing that enzyme replacement therapy doesn't necessarily infiltrate as well into or is taken up as well in the skeletal system, and orthopedists to make sure that their joint related issues are addressed as well. We do also, in addition to non-specific to diagnosis labs like enzyme or oligosaccharides, we do like to check for alpha-mannosidosis patients, like a complete blood count, looking for that yearly or annual blood work can be very helpful. We also like to see, and we don't typically see liver dysfunction in these patients, but we can, or excuse me, as associated with the hepatosplenomegaly, we don't usually see the liver being as involved or having liver dysfunction, but we do like to get a CMP or a complete metabolic panel to look at any liver or renal dysfunction as well. Another lab that is sometimes helpful too is a CRP, or a C-reactive protein, that allows us to look for any evidence of like inflammation, and then any other like imaging or laboratory studies that outside providers find to be helpful. When we see patients on treatment, and what I anticipate for some of our patients that we're trying to get started on treatment for alpha-mannosidosis with Velmanase alpha, is looking at those ongoing motor functions. So looking at an annual or routine 3-minute stair climb, 6-minute walk test. Also looking at pulmonary function, looking to see with pulmonary function testing through a pulmonologist what their forced vital capacity is. This, in addition to trending, hopefully, those serum oligosaccharide levels down over time, are going to allow us to better monitor and report back to families like, hey, look, here's where we were when we started at baseline, and here's where we've been able to get to over time. So that's always very exciting. When we see patients come in too, we always like to ask, when you're getting around the house, are you still using your walker? Are you still using your wheelchair? What kind of things have you been able to do around the house that have made your life easier, your day easier? Before, were you not able to get to the water coming out of your refrigerator because the corner was too tight in your wheelchair and you weren't able to reach up as high? And now you're able to stand up and actually get the water yourself out of the refrigerator. Maybe that's something that isn't necessarily, I like to say, measurable by all of these different standards, but that makes a huge difference in a person's quality of life and in a family's quality of life for their patient as well.
Discuss the challenges of how best to handle the transition of patients from pediatric to adult care.
When we see patients as children, of course, we have individuals who are now in their 3rd and 4th decade with alpha-mannosidosis, and their parents are getting older. It's much more challenging for them to help care for their son, their daughter, when they themselves are maybe starting to have orthopedic or mobility issues. So we definitely see that there is a high caregiver burden for these diagnoses and for patients specifically with alpha-mannosidosis as they age. And, these individuals can have very mild to moderate intellectual disability where they're still able to function and operate on a day-to-day basis, but maybe aren't operating to the extent that they would be able to live independently. So looking into opportunities for where our patients are going to be able to live moving forward and who they're going to live with, who in their family or in the healthcare community is going to be able to provide care for that individual. We also see, and this is across rare disease, and especially with genetics, as our clinic is I like to call it a cradle to grave. So we see patients from the day that they're born all the way through their lifespan. We are very lucky to not have to kick anyone out when they turn 18 or 21. We get to see pediatric patients and adult patients in our clinic. That's not the case for a lot of specialists. We have pediatric specialists and we have adult specialists. So that transition in the healthcare provider team is a really critical time for our patients with alpha-mannosidosis, especially when we start seeing with these individuals, around puberty or in adolescence, really a drastic change potentially in their disease course and their disease progression. That transition is something we deal with all the time, helping parents, providers manage that transition, getting referrals placed to the appropriate adult care specialists, and also navigating the healthcare power of attorney, who's going to be making medical decisions now that the patient is 18, but maybe isn't going to be making those decisions themselves. And so all of that paperwork, all of the legal issues that arise, it's a very critical time in our patients' lives, and we are very hands-on during that time frame as well.
What would you like physicians to know about this rare disease that they perhaps do not?
Wow, everything. I myself have had to learn about alpha-mannosidosis in recent years too. It's not an old dog necessarily, but teaching new tricks. So definitely trying to stay up to date in the research, the literature. When there are new treatments available, keeping those diagnoses in rare disease, especially at the top of your differential, is so important. Obviously, a diagnosis for every person, for every individual, is of the utmost importance to them and to their families. But when we have patients who have a diagnosis that has a treatment that's efficacious and available, just bring that to the top of your list. Because if we can catch that, if we can diagnose it early on, you're going to be creating an entirely different life for an individual. And what better joy is there than that? So I think specifically too, when we're thinking about rare disease and alpha-mannosidosis, if we can help have healthcare providers and researchers really push for newborn screening for these diagnoses, we're going to have an entirely different landscape for treatment moving forward as well. The lives of these patients are going to be so significantly impacted by having early diagnosis, early time to treatment, and preventing a lot of these complications overall. I would also say to any general or specialist providers out there that if you suspect rare disease or something genetic, refer to your local genetic provider. We are happy to take it from there. Navigating genetic testing, navigating biochemical testing, where to send it, how to process the sample, it's complicated. We have a whole team dedicated to doing just that. And my full-time job is that. So if you need help, if you have questions, consult a genetics provider, call us, email us, so shoot us a message through the electronic medical record. We are always happy to consult, offer opinions, and then send a referral. And we're happy to work up those patients.
Thank you, Laura, for your time today and for your excellent insight on this rare disease.
You're welcome, Peter. No, and thank you for your time and your flexibility. I really appreciate the opportunity to talk about something that I'm passionate about, and I hope others can, hear this and maybe consider getting a patient diagnosed in the future. How cool would that be?